agents. Then there are others, we have seen them as a potassium sparing, example spironolactone, which is acting as aldosterone inhibitor, and that will acting on the cortical area, that is the last one, distal convoluted tubule or collecting ducts, it will be acting. This is called as a loop of Henle. You know physiology of urine formation, you should be knowing. And all the drugs which are acting on that, they are called as either loop diuretics or high ceiling diuretics. Example of these are furosemide and others. So these are all diuretics. Basically, as I told you, they act on various ways by reducing the sodium load and by decreasing the fluid volume because of the excretion of, or renal excretion, or increase in the excretion. They causes decrease in the volume, thus decreases afterload and preload. So this is how we have seen. Then what are various neurohormonal antagonists? So these are acting at various places, and they will change the natural history of these heart failure diseases by blocking activation of either RAS, that is renin angiotensin aldosterone system, we have seen it, and sympathetic nervous system. So we have got many agents which are acting, and they can decrease, they can prevent, they can even reverse the process of ventricular remodeling. Yesterday we have seen what remodeling is. They decrease the morbidity and mortality associated with that. So basic mechanism, again this we have studied earlier also, I will repeat it, that is AC and ARB inhibitors are there. These are acting on this angiotensin, renin angiotensin mechanism. So renin is acting, there are drug, if you remember aliskiren, if you remember, we have seen during hypertension. So here renin inhibition is there by aliskiren. Then there are AC inhibitors, there are various enzyme inhibitors, various prils, lisinopril, ramipril, etc. Then they are acting on this, they are calling as a various sartan, valdestrartan, telmisartan, like all this candesartan. Then what are the benefits they are offering? Because of that, this is a series, that is there is a angiotensin 1 receptor which causes vasoconstriction, which causes increase in the oxidative stress, it causes cell growth, it causes proteinuria, it causes left ventricular remodeling and vascular remodeling. These are various effects this angiotensin is having, and these all effects are blocked, they are stopped, and thus the drugs are beneficial. Then other are angiotensin and receptor and neprilysin receptor, neprilysin inhibitor are there. So there is a natriuretic peptide system, we call it as a NP system. This natriuretic peptide, they are doing the regulation of various activities, and these various activities are there. These natriuretic peptides, they are converted into inactive fragments, and this angiotensin and neprilysin inhibitors are there which are acting on this. These inactive fragments are there. In same is the case of angiotensin 2. We have seen that how angiotensin 2 acts, and there are AT1 receptor, they are acting on AT1 receptor, they causes sodium water retention, vasoconstriction, hypertrophy, fibrosis. These are all effects of the angiotensin. While this natriuretic peptide, they causes natriuresis, they causes decrease in the renin secretion, they causes vasodilation, they decreases hypertrophy, they decreases the fibrosis, and they decreases the sympathetic outflow. So this is almost opposite action to that of the angiotensin mediated action. So this AT1 receptors, what they are, their actions are detrimental, they are damaging. So we need the agents which are causing the all the ill effects, all the bad effects of that. While the natriuretic peptides are beneficial, particularly it is believed that natriuretic peptide C is there. So it is converted into inactive fragments, and this neprilysin is acting on that. It improves the balance, it increases the natriuretic activity and decreases the angiotensin activity. So how they are, various drugs are there. Example is drug is Entresto, where the drug is sacubitril. This is a prodrug that will inhibit the neprilysin, it leading to the increased levels of natriuretic peptide. Neprilysin is the agent which causes the metabolism here. Okay, so this neprilysin is causing this metabolism, and this ARNI, they will be inhibiting this. Okay, and because of this this causes the more activity of natriuretic peptides. So these are the agents, and simultaneously angiotensin receptor 2 blocker is there, so it will cause two activities simultaneously. So effects are angioedema, hypotension, impaired renal function, and hyperkalemia. Hyper means more potassium in body. These are the adverse effect. Otherwise effect we have seen. What's your effects here we have seen. What are these effects? It will reduce sodium and water retention. It will cause vasodilation, therefore decrease in the blood pressure. It will cause decrease in the endothelial permeability. It will decrease the hypertrophy. It will decrease the fibrosis. Hypertrophy is very detrimental or damaging factor in the heart failure. Okay, it will reduce the sympathetic outflow. That is good. Sympathetic outflow is responsible for more damage to the heart, because it causes sodium inside, and that causes more damage. So all these effects will be there. This should not be administered simultaneously with ACE inhibitors or within 36 hours of the last dose of the ACE inhibitor, because already ACE inhibition is there, and simultaneously if you are blocking, then it can cause severe action. Then beta blockers, what are the actions they are having in heart failure? They causes particularly there is always increase in the sympathetic outflow, and that causes increase in the beta 1 receptor, beta 2 and alpha 1 receptor. There is increase in the cardiac activity. So this causes myocardial toxicity, and there is an increase in the arrhythmias. So also there is an increase in the sympathetic activity to kidneys. This is why happening, because sympathetic activation in heart failure is there. That is, since heart is not pumping, so the feedback mechanism or cardiovascular center is causing increase in the central sympathetic outflow, and this sympathetic outflow becomes dangerous, because already the heart muscles are weak, they are not doing the job, and simultaneously we are going for hello ha 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 नाही माझ्याकडे नव्हती. शाही मॅडमनी बहुतेक, अरे नाही नाही 100%, नाही 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 बहुतेक शाही मॅडम, मला असं वाटतं तर त्यांनी व्हॉट्सॲपला टाकलं होतं बहुतेक, मी चेक करतो जर असेल तर. ओके ओके शुअर, आलं लक्षात मला, मी बहुतेक शाही मॅडमकडे. हां 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 100% टीम GCPवर शाही मॅडमने पाठवल्याचं मला आता आठवतं. टीम GCPवर हां मी शोधतो मी पण क्लिअर केलं आहे, पण आता कदाचित मी त्याला स्टार करून ठेवलं असेल कामाचं म्हणून तर असेल, है ना. ओके ओके हां. So these are the various activities which are occurring over there, and definitely this beta blocker will block this action, and therefore it will be saving. Then mineralocorticoid receptor antagonist, that is aldosterone receptor antagonist. Example we have seen spironolactone, and this will be important. We have seen yesterday how it is useful. Okay. Then next is ivabradine is a new drug. How this drug is acting? It is acting on particularly hyperpolarization activated cyclic nucleotide gated channel blocker. So there are channels, and these are activated after hyperpolarization, and these cyclic nucleotides are there. Okay, cyclic nucleotides means like ATP, like this. So these are the cyclic compounds, and they are nucleotides. Cyclic AMP, cyclic GMP, these are guanosine, adenosine. Okay, so these are nucleotides because it has got this nucleoside plus base, everything is there, plus phosphate is there. Okay, and they are cyclic in nature. So example of this, and these are the channels are there for that. So whenever hyperpolarization takes place, these channels are activated, and this causes the changes in the heart muscle accordingly. So these drugs will reduce the diastolic depolarization slope in the SA node, and thus decrease the heart rate via direct sinus node inhibition without direct effect on the myocardial contract. So myocardial contractility will not be changed, the force of contraction will not be affected, only the rate of heart will be decreased, and intracardiac conduction will also be remaining same. No impact will be there on the intracardiac, that is SA node to AV node, that will not be there, only heart rate will be changing. So it is indicated to reduce the risk of heart failure hospitalization in the patients with stable symptomatic chronic heart failure, where the left ventricular ejection fraction, LVEF, means left ventricular ejection fraction, is less than 35%. Okay, now as I told you, how much is problem, that will depend person to person, but below 40 is very dangerous. Even below 60 you need a treatment, but below 40, that means it is a very big. We shall be seeing various classes of it. So in that cases we need a good treatment. So in that ivabradine can be used in that treatment, particularly the person who are in a sinus rhythm with resting heart rate is greater than 70 beats per minute, and they are either on maximally tolerated dose of beta blocker or have contraindication to beta blocker. I told you earlier, this is a very typical situation. If you are the drug expert and you are asked to prescribe the drug, you have to take a very, very judicious decision whether beta blocker to be given or not, because I told you beta blockers are saving it, beta blockers are protecting it. However, in certain cases, when the heart pumping is reduced too much, then rather we have to give beta 1 agonist, example dobutamine we have seen, or we call it as an inotropic agent. So inotropic agent has to be given in that particular condition. Okay, so this is very typical situation, and on the particular condition, whatsoever condition will be there, on that basis the treatment has to be done. Then hydralazine and isoardyl, these are, hydralazine we know it is a vasodilator, and isosorbide dinitrate is another one vasodilator which we have seen in angina. So they are recommended to reduce the morbidity and mortality for the African American person. They are indicated for the patient with left ventricular ejection fraction which is less than 40% and who cannot tolerate ACA inhibitor or ARB, which is because of the secondary to renal insufficiency or already kidney problem is there. So in that ACA inhibitor, ARBs cannot be given. So in that cases we cannot give this. So hydralazine and isosorbide dinitrate, they are useful, they can be given. So what are the benefits of various drugs? So this ACE inhibitor or ARBs, they causes reduction in mortality up to 17% of the patient, and they can reduction in the hospitalization time in 31% of the patient. Beta blockers are useful in almost 34% of the patients, and they can reduce hospitalization in 41%. Aldosterone antagonist, example of that is spironolactone. It is 30% reduction in mortality and 35% reduction in the hospitalization. Hydralazine nitrate combination, just now we have seen, it can give benefit in 43% persons, and there can be 33% reduction in the hospitalization. So these are the benefits which are been observed, and this type of data is providing inputs for the pharmacotherapeutics when you will go for that. So these are the studies which are important. This type of studies shows that which is beneficial. So we in pharmacology we study all the classes. We do not give much attention what is to be preferred in what condition. But in therapeutics, you will have to utilize this data to prefer which drug has to be used in what condition. So digoxin we shall study in somewhere more detail. Digoxin shows no mortality benefit. decreases the hospitalization. However, it increases the exercise tolerance, and it may help for the rate control in the patient with the atrial fibrillation simultaneously. Which drug are to be avoided in heart failure? So all NSAIDs, non-steroidal anti-inflammatory drugs, because they are affecting renal function, and therefore they can cause renal insufficiency and therefore accumulation of water. So these NSAIDs are not used. NSAIDs are very commonly used. Example, paracetamol, etc. These are the painkillers. Then thiazolidine diones are there, which are used in various diabetic condition. Calcium channel blockers like non-hydropyridine, means those which are non-dihydropyridine. Which is dihydropyridine? Dihydropyridine is